Good morning. Pleasure to be here. I will be presenting a lecture by Dr. Ricardo Pérez Jiménez, an orthopedic surgeon and a spine surgeon in Mexico. I thank the residents for the invitation and for this initiative, and I congratulate you all for having the initiative and participating in all this virtual congress. I am going to talk about compression fractures secondary to osteoporosis and their clinical, surgical, and therapeutic options. In this presentation, I have no conflicts of interests. As an introduction, osteoporosis is a systemic disease characterized by low bone mass. Remember that it is one of the most important metabolic diseases in the world, the third at the moment among the elderly. It causes great impact on the world's economy, which is also why it is important that we are familiar with this subject. It is characterized by an alteration in bone microarchitecture and a reduction in bone quality. As we can see in the image above, a healthy vertebral body with its trabecular system compared to the image below, where we can identify the radiological sign known as the box sign, where the trabecular system is significantly diminished. There are two causes of osteoporosis, primary and secondary. Secondary is more often seen in patients being treated with corticosteroids or a patient treated for some disease, like chronic kidney disease. In this lecture, we will focus on primary osteoporosis. It's divided on primary type 1 in postmenopausal women, and then primary type 2, which involves both men and women who are elder. As I mentioned, it is an important public health problem right now. With the increasing average lifespan, osteoporosis incurs many costs in health care systems. Also, treatments are expensive, and this causes a lack of adherence to treatment. All fractures leave sequels, and fragility fractures on the vertebral bodies are no exception. It's a fracture that leaves sequels involving restrictions on movement, chronic pain, and, well, when it becomes a more significant collapse, it leads to a deterioration in the respiratory capacity of patients. The diagnosis of osteoporosis is done at the first level healthcare center or in contact with the general physician through the FRAC scale. This scale is based on a questionnaire that can give us risk factors that predict the diagnosis of a very probable osteoporosis, and we can start treatment. In the hospital, we would make the diagnosis through a bone densitometry, where the T-score, if the T-score is less than 2 standard deviations, we would have the diagnosis. This should be measured in the spine or femoral neck or an osteoporotic segment. However, here in Mexico, we often see fractures due to osteoporosis that are underdiagnosed, even in the spine, and usually the patient has had not a densitometry done, and we see them in the doctor's office due to a fragility fracture. And well, that's when we see the fracture, like the image to the right, a fragility fracture. It gives us the diagnosis of osteoporosis. We should start treatment and complement diagnosis with a densitometry. Fragility fractures, we found their incidence in the literature to be very high. We were surprised by the number of fractures due to osteoporosis per year. We normally have the idea that they are fractures of the wrist or distal radius, the most common, maybe even the hip. But these figures, we realize that the spine is the most affected by this type of disease. And we also found an important point in the data that they mentioned. Half of postmenopausal patients will have a fractures due to fragility at some point in their life. Returning this back to healthcare costs, this imparts great repercussions on the patients and for their health and for all the patients that are becoming elderly. Also, we found that a patient who had a fragility fracture increased the risk of having a new fracture by 12%. We mentioned the sequels of a fragility fracture, including pain, not disabling, but a chronic pain in which the patient has to take medications for a large part of their life. It also causes disability, premature mortality, and this is related to the collapse of the thoracic cage and decreased lung capacity, and this reflects in the premature mortality. Here, endocrinologists are the experts in the management of osteoporosis, which is why we based ourselves off an endocrinology journal, where they mention that there are always 4 principles that we must follow to diagnose and treat osteoporosis. First is to assess the risk of fracture in postmenopausal women. Second, increase treatment adherence. We should have the ability to know which patient is going to adhere to a treatment, taking into account treatment cost and economic intake, since there are daily, weekly, monthly regimes, and even 6 months regime. So strategically on our end, if they have a good family support network, they can learn which is the best treatment option for them. Third, medical management should be complemented by changes in lifestyle. Always mention to the patient that physical activity and daily walks are important. Their nutritional state must be in a perfect condition. Patients who smoke should reduce their intake of tobacco and also of alcohol. 4. Pharmacological treatment also reduces the risk of fractures. Their benefits beats its risks. Here we have the 4 types of treatments. Some are anti-resorptive and some are hormonal to stimulate bone production. We're going to talk about bisphosphonates. This table shows the relative risk associated with bisphosphonates in hip fractures. Red arrows show bisphosphonates example, and all bisphosphonates have certain side effects and contraindications like stage 5 kidney disease. We should always reevaluate in 3 to 5 years and consider a bisphosphonates break. Some examples: alendronate, it reduces the risk factor by 40% when administered daily, weekly, depending on the presentation. And zoledronic acid was one that showed the greatest reduction in risk of fractures. This medication also has a much greater adherence to treatment since there are less side effects, heartburn or reflux, and its annual dosage, so it has a little more adherence to treatment. We found it is a good start for treatment. Personally, the type of medication that I use is zoledronic acid. Monoclonal antibodies, we have the denosumab. I also use this personally, and it also has a very high patient adherence since it is administered every 6 months subcutaneously. There is no contradiction in a patient with alteration in the glomerular function, and the downside is the rebound effect if it's interrupted in less than 6 months. It should be evaluated every 5 to 10 years. This means we can suspend the treatment without being necessary to replace it with a bisphosphonates. It means we can wait 5 to 10 years without anticipating any problems, and it is removed sharply without losing the bone mass gained. The medication that has much better evolution and much better effect in the reduction of vertebral body fracture is teriparatide. an analog of the parathyroid hormone, and the only disadvantage is that it's very expensive and it must be implemented for at least 2 years, and not until then you can consider changing it or suspending it for another anti-resorptive. Another small con is that its application is daily, but now it comes in a pen where we explain to the patient that it should be applied in a subcutaneous manner as if it were insulin. Here we see an image of how teriparatide works for 2 years. We can see in the table at the beginning of the treatment and at 24 months how initially it's predominant bone formation in our patient. But we see how after 24 months the anabolic window closes and the predominant effect is bone resorption. Therefore, it is recommended to carry out the treatment for 2 years and then suspend them. It has been shown that teriparatide at high doses generates resorption. That means that it increases the activation of osteoblasts and osteoclasts. An example of this is a patient with primary hyperparathyroidism. However, if on the other side we give teriparatide at low doses, like we usually do in the treatment, low and repetitive doses, it increases the production of osteoblasts, as I commented in the image we see here to the right. Now focusing in the morphology of vertebral fractures due to osteoporosis, we have these 3 forms of fractures: in wedge, burst, and when they are biconcave. When it's in wedge, we see that regarding the columns of Dennis, only the anterior column is affected. Burst factor is when both anterior column and the middle are affected, or collapse and biconcave when the platforms have an image biconcave or in the form of a fish vertebra. Generally, the injury mechanism is an axial load, whether they are falls from their own height on their bottom or even in a car drive going fast through a speed bump. With that simple low energy mechanism, it can cause vertebral fractures. You can also classify it as a stress fracture when there is a cyclic repetitive movements causing the vertebral fracture. Here are the 3 grades of fracture: mild, moderate, and severe, depending on the percentage of the vertebral body collapse. Clinically, the patient is going to have back pain. Depending on the level of the fracture, an irritation of the nervous root could exacerbate the pain. At the beginning, the patients think that it is obviously because of a fall or a sudden jump they had, although up to 50% of the patients don't remember the moment of injury. A back pain that doesn't stop and a pain that can increase progressively, since the vertebral body may continue to collapse, and that can continue to cause pain. One of the main clinical signs is when the patient presents with kyphosis. We have all had to see elderly patients who present kyphosis. This is due to the collapse of one or multiple vertebral bodies. And literature shows us that when we have kyphosis, the patient's breathing capacity is reduced by up to 9% per vertebra. As for differential diagnosis, we always have to think about tumors, metastases or primary tumors. And well, when there are radiographic lytical signs in the cortical bone, that makes us think more about these types of tumors. There may also be some soft tissue masses, such as hemangiomas, which can also reduce the bone mass. We could also have constitutive syndrome. Radiographically, we will always start with a spine X-ray, and we must clinically correlate them with other office studies. These images are very, very important because we can see that in the lateral X-ray, we do not observe a collapse in the vertebral body. However, the patient had a lot of pain, therefore an MRI was taken, and that is where we can appreciate the wedge fracture. In the MRI, we're able to observe edema caused by the fracture, especially in the sequence. A CT scan is also indicated to be able to observe the bone in detail, to able to observe all the trabecular system and the cortical walls of each vertebrae. CT scans are also used for pre-operative planning, and we will talk about that later. But with CT scan, one of the most important points is to define the treatment we will propose. And it is important to observe if the fracture involves the posterior wall or the medullary canal of our vertebral level. And that is something very important that we must verify. In the image to the right, we can observe some quadrants, where quadrants 1 and 2 are the safety zones, where we can perform our plan with higher security. And that is how the CT scan serves us, and it is useful for those two functions. Well, now we will define the treatment plan. On one hand, we have the medical and conservative treatment plan of fractures, and it is generally managed through anti-inflammatories, analgesics, rest, the use of a corset, and even physical activity, although this last one will be limited for approximately 6 to 8 weeks based on the progress of the patient. The disadvantages of conservative treatment are that the deformity and chronic pain may persist in the area of the fracture, mainly due to the wedging. Afterwards, the patient must take strong analgesics and even opiates to control the pain. I even had one patient that I managed conservatively that it even masked abdominal symptoms of an appendicitis. So we should not have our patients becoming dependent to opiates or taking them in a consistent basis. So on the other hand, we have the surgical plan. We are proposing a vertebroplasty and a Cifoplastia. Both are done percutaneously and in the operating room. And the purpose of this operation is to inject bone cement into the vertebral body to fill those empty spaces that exist by the vertebral collapse and the sequel left by the fracture itself. The vertebroplasty started in France approximately in 1987, and after that it evolved and Cifoplasty was created. Cifoplasty is basically the same principle. However, as we can see in the image to the right, a balloon is introduced and insufflated so that it helps restore the height of the vertebral body, and after that, the application of cement to fill those remaining empty spaces. This Cifoplasty was first performed in 1998 in the USA, and it is a relatively new technique that can be combined with other therapeutical options. For example, there are some patients who present with vertebral collapse, but in the adjacent vertebra, either above or below, they may also present with the empty box sign or present with a minor collapse, but still a collapse. So we can apply in our target vertebra, our main fracture, we can perform a Cifoplasty and reinforce the procedure with vertebroplasty on the adjacent superior and inferior vertebra. And that is how we could even perform a hybrid treatment that way. The bone cement used for these techniques is different from the one we know from knee or hip prosthetic hip replacement surgery. This is a high viscosity cement, and as we know, the radiopacity is produced by barium sulfate. An important concept of this cement is that it hardens through an exothermic reaction of up to 41 degrees Celsius. This is why it's called cold cement, opposite to the cement used in hip or knee replacement surgery, because the temperature rises much more in those cases. And what this cement does, as I've said, is to fill the space of the vertebra in order to stabilize the vertebral bodies with the cement itself. The amount of cement that we must introduce will depend on the technique that we choose, either vertebroplasty or Cifoplastia. Approximately, we will introduce 2 to 4 cc of methyl methacrylate for each pedicle. So that what we're saying is that a vertebra to which we will perform a bilateral Cifoplasty, we can introduce up to 8 to 10 cc of cement, depending a lot on the degree of collapse and depending on the height that we can restore. As surgeons, we should always be aware of all the small details, like the temperature of the room, so that it is in suitable conditions. It should be 23 degrees Celsius plus minus 1 degree. This will help the forming of our cement, and as it becomes a suitable consistency after a few minutes, and we must be careful not to be in a hurry or introduce too liquidy cement to the vertebra. Because obviously if we introduce it too quickly, there is a high risk of extravasation. In the other hand, if we introduce it too late, when the exothermic reaction has settled, we are no longer going to be able to introduce the right amount for each vertebra. So an indication for Cifoplasty and vertebroplasty is a vertebral fracture secondary to osteoporosis with acute pain and less than 60% of the vertebral collapse. As I mentioned before, the majority of these patients are underdiagnosed, and they arrived at the doctor's office approximately a month or a month and a half after the fracture occurred. However, if the pain still persists despite those weeks that have gone by, and it's no longer considered a recent fracture, but it can be treated to reduce discomfort. As I mentioned before, we can fill those empty spaces of the fracture of the vertebra that is collapsed. As the cement expands, the fragments are stabilized, and that reduces pain by a higher percentage. Another indication in bone metastasis or multiple myeloma patients where the vertebra with possible fractures and cementation can also be used prophylactically. Contraindications include old asymptomatic fractures when the patient has had history of infection, either of the disc or the vertebral body itself, and fracture that compromises the posterior cortex. Like I mentioned on the previous slide, we should be attentive to check the integrity of the entire back wall so that we can offer this type of technique. Getting into the surgical technique, this is done in the operating room, preferably having a radiolucent table that allows us to make the fluoroscopic arm move both in AP and a lateral position. Personally, there are some articles where they recommend doing this procedure under sedation. However, I would recommend under general anesthesia. We should make sure we have the proper radiologic protection equipment for the entire surgical team. As I mentioned, this is a percutaneous technique through the pedicles, and for every portal that we use for the fracture, we will only make an incision of approximately half a centimeter. I recommend getting an AP view. To achieve this, we would locate the fracture and we would go in the AP view so we can begin our percutaneous technique. This can also be done bilaterally, simultaneously, when we have an experienced assistant, and thus save a few x-rays. But here, as we can visualize in the image, we're going to introduce the Jamshidi cannula. It has a cutting tip, and we are going to direct it in the upper external quadrant of each pedicle, and we're only going to support it on the bone. It should be marked in the margin of the cortex of the pedicle. Once we have that vision, we will advance percutaneously, and there we will be introducing the Jamshidi cannula to more or less the center of the pedicle, and keep advancing until we reach step 3 in the AP view. Also, it is not necessary to touch the medial cortex on the AP projection. You can continue in step 2, and once we feel that we have advanced approximately 1 or 2 centimeters maximum, we would find ourselves in step 3. If we see in the step 3 that in the AP view we have not violated the medial cortex, and we go in the lateral projection and we are already arriving into the vertebral body, this is a great reference point to say we are in our safe zone. Once we arrive on the vertebral body, the Jamshidi cannula should be introduced approximately half a centimeter or a centimeter halfway through the vertebral body, always directing it, depending on the collapse we have, always directing it to the middle of the body. Once we have inserted it that way, we're going to remove the cutting needle from the Jamshidi, and we're going to introduce a guide pin, which should have a blunt tip. It is very important to not just put any pin. It is a guide pin that must have a blunt tip. With so much bone fragility, sometimes when we put in the multiple shirts, you can introduce it too far and break the anterior cortex of the vertebral body, and will, depending on the level, we can find ourselves with big vessels or the mediastinum or abdomen, depending on where we're working. Once the guide pin is placed, the entire Jamshidi cannula is removed, and we can see it in the image to the left. A cannula or work shirt is being introduced. For this, we do the same, directing it with fluoroscopic control. Once we managed to introduce the work shirt more or less half a centimeter to 1 centimeter of the posterior cortex or the posterior wall of the vertebral body, we will introduce a drill bit that has the function of removing chips or regularizing the edges within the vertebral body. This is in case we want to place a balloon well so the chip of the fracture don't deflate the balloon. In other aspects, the drill bit can help us to take biopsies when we suspect of any tumor. with this drill bit always turning in a clockwise direction. This includes the moment you introduce it and the moment you remove it, so the bone tissue is captured, and we can carry out the captured tissue through the worksheet. And well, that's also how we can obtain biopsies. This is when the technique splits. At this point, we're only going to talk about vertebroplasty, and it is something now very simple because at the moment, after removing the drill bit, we just have to verify our cannula and worksheet, verify that we are in the correct position in the safety quadrants, both in AP and lateral view. And we're going to introduce the cement. Here I recommend the introduction of the cement is always in the lateral projection and with direct fluoroscopy. Here we have a case of a patient where in the lower vertebral body a cifoplasty was performed, and in the higher or the superior vertebral body a vertebroplasty was performed. Then here you can see in the lower vertebral body how there was a much more opportunity to introduce a greater quantity of cement, and in the higher vertebral body only a small amount of cement that is occupying the trabeculars that were empty. Something else that is important is you can do it with your work unit. It's to perform with neuro monitoring. All these little cables that can be seen in the image, well, it is all the neuro monitoring during the surgery, and this will help us during the introduction of the cannulas as well as the application of the cement. And so the cement is applied under direct fluoroscopic visualization. We must do it in the lateral projection in case at any time we find any extravasation at the level of the medullary canal. When we're going to apply the cement, I recommend that it's done unilaterally. This is first one surgeon is going to apply all his cement, and then the second surgeon is going to apply the rest of his cement in the other side. So if there is an extravasation, we know which side it is from and where you can continue to apply cement and where you have to stop. And apologies for the title. Now we're going to focus only on kyphoplasty. Once we have the working shirt, the balloon is going to be introduced. The balloon has these X-ray signs that guide us and mark our limits. And once we're in the safety zone and where we want to restore the vertebral collapse, there we're going to leave the balloon. As seen in the image, we are working bilaterally. There are two cannulas and there are two balloons, and it's going to insufflate with the key shown to the left. It is introduced through the syringe. Contrast medium is introduced through the syringe, and we're going to see how it's going to expand the vertebral platform. We must do it with approximately 100 millimeters of mercury, so as not to burst the platform, and also so we don't burst the balloon. Before introducing the balloon, they should test the balloon on the outside, so we make sure that there is no leaks and that it's working properly. The same thing, it can be applied with two balloons or with one balloon. Everything depends on the costs, because, well, obviously the commercial entities, they profit for each balloon. However, we can introduce in a pedicle to make the balloon expansion, deflation, and then we go to the other pedicle and we do the same thing. As I mentioned before, in the image, in this case, we have two balloons. However, well, that would be a question and decision for each surgeon. Here you can see those same two balloons as they were insufflated, and how the height of the vertebral body expanded once the balloon had been insufflated. both lateral and AP projections should be also provided so that we observe the posterior wall of the vertebral body and if it has been fractured. Okay, this is the example of the patient that I told you we had under neuromonitoring, where we first introduced the balloon on one side of the lower vertebral body, and then we introduced it in the contralateral pedicular, and the cannulas of the superior vertebral bodies are ready to receive our vertebroplasty. Then once we have restored the height of the vertebral body, it is when we indicate the technician who is supporting us to begin making and preparing the cement. And once the cementation is done, this is how we see the x-rays. Complications of Cifoplastia and Vertebroplasty includes extravasation of the bone cement in 10% of the cases. We can limit all this to the maximum, taking the precautions I mentioned in the CT scan, monitoring the integrity of the back wall, and introducing the cement with direct fluoroscopy, as well as neuromonitoring. Another complication is the risk of fracture of the adjacent segment, and that may be in the 2 months to 2 year follow-up. We can solve it by doing what I mentioned. That is, if you observe the adjacent superior or inferior vertebra have clear signs of low bone mass, you can perform a vertebroplasty in those segments as prevention of this type of fractures. And here we see in the image complication no one wants, which is the bone cement to go into the spinal canal. In my practice, I have the opportunity to see a patient that was not treated by us. However, he had this complication, and the patient presented with paresthesia symplexia in the immediate post-surgical period. Fortunately, the patient recovered, but it was kyphoplasty performed at the lumbar level, and only one nerve root was affected. He had pendulum foot, and after 6 months, he recovered without any problem. And within the post-operative care, relative rest is suggested. This is usually an outpatient procedure. However, the patient can be kept under observation approximately 6 to 12 hours and can be sent home if there is no complications, obviously. We can also order a CT scan or x-rays. This can be performed to verify that the cement is in its right place, and if there is any indication that the patient should be left under surveillance. When we discharge our patients, we should also protect the fracture of the adjacent segments with a corset, which are going to be used more or less from 4 to 6 weeks. And that would be everything. Again, I thank everyone for the invitation, and I congratulate you for this initiative. I hope that something was of use, and we are here to serve you. Good afternoon. See you later.